Okay, ladies and gentlemen, this sort of health data, sort of data that's being collected, those heat maps and those trajectories and that accelerometer trace over time, GPS, and all these different things, the things we talked about, like recording electrodermal response or heart rate variability and so on. How do those fit into kind of the landscape, the universe associated with health research? Well, I'd first highlight that they are examples, and in some cases perhaps exemplars, of what is often called big data related to health. But they're by no means the only examples of that. Increasingly, researchers across the world are seeking to secure insight into health behavior, health exposures, attitudes, knowledge, beliefs, by leveraging tools from a real large universe of different data sources. These include social media, such as Twitter and Facebook. Facebook status updates, Twitter feeds. All around us are environmental sensors collecting data. We're typically unaware of them. They collect data predominantly in a passive way that doesn't make us aware. But a building like this, particularly recent buildings, are essentially robots of sorts in the sense that they regulate the internal temperatures and so on and airflows by virtue of measuring things like humidity, temperature, pressure, etc., and adjusting the building environment accordingly. Such sensors can be leveraged for understanding health insights, such as the outbreak and nosocomial infection outbreak, which depends on humidity conditions and temperature for breathing. And all around us are things like weather sensors that help us know just how much rain we're getting out there. Municipal sensors having to do with air quality in larger municipalities like LA. We could also put into there, with some reservations, things like lab test results and administrative data, which are large-scale electronic data sources, but have a lot smaller velocity, as we'll be talking about. So they're kind of borderline. Point of sale records. When you buy something, there's an electronic footprint that's created. If you buy something from the pharmacy, if you go and you purchase some sort of medical device, a lot of these things are traced. And even if you purchase food, right? If you purchase products for wellness or for physical activity, often there's relevant point of sale data that will help us understand, eating patterns, for example. Questionnaire responses. I noted that those sample questions trigger questionnaires, and we saw some examples of that very briefly in our overview. Audio from a person's voice. We saw how that was recorded for some of the surveys, for example. In some cases, people track incoming and outgoing calls to different numbers to understand something about communicational behavior, support networks, etc., and the dynamics of those networks. Proximity data to communications infrastructure like cell towers has been used to give insight into people's movement and mixing behaviors. Information on health browsing is something that is of considerable interest to communications researchers, such as our partner Vishwanath at Harvard, where they're interested in understanding people's exposure to health messaging, adverse and positive online, whether it's sites set up such as WebMD to try to support understanding of health concerns, or whether it's adverse forums set up by tobacco companies, trying to understand how people's browsing behavior brings them in contact with health information. And of course, all through much of this bootcamp, what we're emphasizing is how consumer electronic devices and sensors, for example, can help us understand health insight. And increasingly, we're surrounded by consumer electronic devices that, whether we are aware of it or not, are collecting lots and lots of information about our current activity, our current exposures, our context, etc. Now, what is it that distinguishes these sort of data from traditional sorts? What are some of the hallmarks of this sort of data? If we want to think about this sort of new type of information in the context of our already rich set of rich landscape when it comes to collecting health data, what do these really bring to the table? What are some of their distinguishing characteristics? Well, some of those dealing with big data as more general phenomena, particularly those at Google, have emphasized what they call the 4 V's of big data. And I think it's actually it's the least bad of any definition I know of for big data. I think there's lots of bad definitions, and certainly an overhyped term, but these are 4 that I think are substantial and meaningful, particularly in the health context. The 4 V's refer to volume. There's lots of evidence. And really, when people think about big data, this is the thing that attracts their attention. This is the thing that dominates their thought. Wow, you get lots of data, collected in databases. Lots and lots of data on GPS traces or physical activity over time or what have you. But I think actually, perhaps even more significant than that, with greater significance to health insights, are the fact that it's high velocity. What I mean by that is the data is coming in really quickly, sometimes several times a second, and other times several times an hour, but at a very high rate compared to traditional instruments. Rather than sending out a survey instrument to be filled out at the end of the month, reflecting on fruit and vegetable consumption for the month, or level of physical activity reported, we're instead getting these measurements many times a day, and perhaps much more often than that, perhaps every few minutes or even more frequently. So velocity, variety. There's cross-linked data sources that are being collected that allow for triangulation about really what's going on in someone's underlying situation. There's a lot of different pieces to the puzzle that are being tracked for a given person that can give a better understanding of the whole person. And then finally, veracity. And it turns out there's 2 major components of this: physical measures for things like fruit and vegetable consumption, diet, physical activity, sedentary behavior, social mixing, movement patterns that are traditionally very hard for people to recall and report accurately. So there's physical measures that replace faulty memory and reporting bias as well as recall bias. But then there's also the fact that we have several different types of sensors pointing to the underlying situation that can often clue us in. Any one sensor may be very ambiguous, but collectively they paint a pretty clear picture. Let's talk about each of these in turn. Let's talk about volume, the first of the 4 V's. So we're going to go through volume, velocity, variety, and veracity. So let's talk about volume. So with volume, if we give some names to common quantities here, the number of participants, we'll call it capital N in common parlance. Number of records per participant for M. In traditional epidemiological studies, it's very often the case that we have N rather greater than M. Even large-scale survey instruments such as the Canadian Community Health Survey, the National Population Health Survey, or in the States, the NHANES study, National Health and Nutrition Examination Study, or National Health Interview Study. There's a lot of questions asked per participant, but there's tens of thousands or hundreds of thousands of people involved. So for many traditional epidemiological studies, certainly by no means all, we have a number of participants that's much greater than the amount of information we gather per participant. For big data, it's not at all uncommon that we have the reverse. We have lots and lots of detailed insight on each participant, and we may have a large number of participants, but it's dwarfed by the amount of information we have in the participants. Tens of millions of records on a given participant, perhaps hundreds of thousands of participants, or tens of thousands. Still big N, but much bigger M. And so we might commonly have here dozens of megabytes per participant per day collected. Now, megabytes is a measure of recent vintage in the health area, but we're talking about tens of thousands or hundreds of thousands of records per person per day on things like their GPS location and their physical activity or their heart rate variability as a measure of stress and electrodermal response, etc. Now, why is this relevant? Well, the volume of data often requires different handling techniques than for traditional data. It requires different mechanisms in terms of storage. It requires different, now that's real plumbing, and probably for most of the registrants, this is less of interest. We have to store this thing in boxes that look different, and with software that looks different. Okay, that's probably below the level you care about a lot. But it certainly is going to affect analysis, visualization, and our attempts to understand the data. We use different kind of ways of interacting with the data, different constructs to understand what's going on. So just to give you a sense, maybe you want to do this interactively. Why deal with slides? Let's go to one of these studies. Let's go to the that physical activity sample study, and let's go to overview there. Okay. Let's turn this interactive. So we have this overview on this study, and you'll notice the study information that's being recorded here. Okay. Now, Mohammed, maybe you could tell me, is there a place where these statistics have now been moved to here?
Or the number?
Yeah.
We moved it out because it wasn't of interest to me.
Okay. Okay. Oh, great. Okay. Okay. Now I'm in. Okay.
Yeah.
Yeah. So, ladies and gentlemen, you'll notice that these different types of information are collected.
Just one thing, sir.
Yeah.
If you go actually to compliance, you can just have a sense approximately how much.
Okay. Okay. Fair enough. So we'll go to compliance. We'll go to this user 231, and we'll look at that user over July 9th to August 8th, and we'll collect their accelerometer stream. Okay. And we'll say go here. Boom.
As you move your cursor on that, it just shows how many records per hour.
Right. These are records per hour, and you can see that these vary. Commonly it's around 2,000 per hour. 2,000 data points per hour. Pretty large volume of accumulated data. This is a study we were running, and this was actually only a month into this study, and already we had about 60 million accelerometer-related piece of information, and there's a study of about 40 people, I think, in this phase 2, group 2 or so, for about a month's time. Survey responses, we had about 4,800. GPS, about 7.5 million records. And actually, accelerometer, about 91 million. We're talking about volumes of data that are large, gyroscope of 121 million records. Now, you may be wondering, why do we need accelerometer and gyroscope? It sounds awful geeky and so on. Yes, but if you actually want to understand, it turns out these things become really useful. And we'll be unpacking that later. But if you want to understand, are they carrying the phone with them right now? Are they sitting, standing, lying down? Are they engaged in sedentary behavior or vigorous physical activity? These things that seem very geeky actually become valuable. And you can recognize at a very detailed level, temporally, aspects of their physical activity, their sedentary behavior, aspects of their physical environment, which may be of great interest. Okay, let's talk about a second V, velocity. These data sources update frequently. The data comes in quickly. It's high velocity data. We're receiving it quickly. Now, when I mentioned electronic data sources, some of those data sources exhibit much faster recording than others. For example, lab data and administrative data exhibit rather slow accumulation of data. By contrast, and that's why I say they're kind of borderline whether they're big data. They don't really qualify that well along velocity. So maybe from administrative data perspective, you're recording billing information from contacts with the healthcare system. You might get a couple updates a month. From lab data, you might get big chunks from lab images and from assays done while you're in the hospital in a faster way. But it's at fairly low rates. Medium to low rates, I would say things like Facebook updates, Twitter, browsing behavior, app use, etc. I saw a statistic at a recent conference. Twitter, something like, I believe the statistic was something like 8 tweets are sent per second worldwide. So every second, you've got something on the order of 10 tweets coming out. But for a given user tweeting out, or a given Facebook user, the status updates are occurring maybe a couple times a day. Same thing with browsing behavior. You might get a flurry of pages, at certain times during the day.
The number actually is 6,000.
6,000? Oh man. Okay, I was told 8, but maybe it was 8 about health-related things or something like that. 6,000 per second.
Per second.
Worldwide.
Yes.
Okay. Thank you very much. Ecological momentary assessments. These might be filled out a bunch of times a day, and generally we found we can comfortably do that and still tend to get pretty good adherence. Medium rate, these are things that update on order of a second, of seconds. So things like building sensors, perhaps GPS every 30 seconds or something like that. If you think about driving in the city, every minute. Higher rates yet, many times a second, things like accelerometers, gyroscopes, electrodermal response, heart rate variability, heart rate, etc. Quite fast. And compared to traditional instruments, which might be filled out once a month, a few times a year for a longitudinal study, we're talking about something that's very high velocity, very high velocity. And what's the advantage of that? Well, it provides high temporal resolution. And often we're interested in micro behaviors, right? We're interested in those instances of suicidal ideation, those changes in cognitions related to tobacco use for someone who's struggling to quit. If we're interested in understanding the day-to-day dramas and challenges of someone who's quit, then this sort of high temporal velocity data is very attractive. Okay.
This is working. It's recording right now.
Oh,
and it's recording
even as we speak.
Even as we speak, it's recording this desktop, and there's your camera.
Got it. Okay. Okay. Fantastic. I'll switch over to this then for my next thing. Grateful for that. Okay. Let's talk about variety. V. A given electronic. There's 2 components I think of to the variety story. Number 1, a given electronic data source. Let's take thanks a ton, Ru. Yep. A smartphone or a smart watch. They're often providing multiple lines of evidence. Amin here, last week in this very building, undertook a heroic sort of exploration of the capabilities of a smartwatch working together with Empatica. He was well supported by Mohammed in this closely. And the smartwatch we're using, the Empatica smartwatch, is recording a whole bunch of different sensors, including accelerometry, electrodermal, heart rate variability, heart rate, skin temperature, which are all coming from that one device. And it's quite useful to have that information from that device. So if you're trying to recognize the smoking behavior based on that watch alone, you can do a lot, because you've got heart rate variability, which is changed by nicotine use. You've got heart rate, which is often also affected. You have acceleration, which might catch the sort of movement of the hands back and forth with a cigarette. You could potentially capture some related insights via the electrodermal activity. For smartphones, we're collecting, well, you'll see the full set of it, but it includes factors related to location, physical activity, proximity between people, posture, humidity, responses to ecological momentary assessments, these questionnaires, button pushes to indicate things, etc. So from a given device, we're getting a lot of information. And then often we're going to have multiple sorts of devices or multiple sources of data available for a given person. So it might include smartphone and smartwatch, as Amin and Mohammed built last week. So it might involve a partnering, while you're carrying your smartwatch, you've got your smartphone, consolidating the data, combining it with the reports via the ecological momentary assessments from the smartphone. You might have weather data regarding the fact that it's raining or it's minus 35, or don't worry, it's not yet, or that it's very, very sunny and a high UV exposure, that you would link with this information to deduce risk, right? So we might know, for example, the time, and based on the weather, there's a high risk of mosquito exposure, and from a smartphone we can get an understanding if someone's likely inside or outside, which helps us understand something about risk. We might have point of sale data or Facebook updates that provides further clues. Now the point is here, folks, that not only do we have this sort of information on people, we cross-link it. We can cross-link it by the participant and the time. So for a given participant, at a given time, we often know many sources of data that we can bring to bear. So by linking the fact whether they're inside or outside on the one hand, using smartphone data to weather data, we can understand something about the weather exposures, the level of UV that they're experiencing. Through an EMA, we can know whether or not they're wearing personal protective behavior, like a hat, to protect them from the UV. So the cross-linking is key, and that cross-linking allows us to triangulate sometimes the state of a person from multiple lines of evidence, okay? We'll come back to that point in some of the analysis discussions, but suffice it to say that if we're trying to understand, for example, if someone's standing, sitting, lying down, or active, we will often leverage multiple lines of evidence, multiple sensor types. If we want to understand someone's indoor or outdoor, we might look at things like the Wi-Fi signal strength, the GPS availability, the GPS signal strength. We might look at whether the phone is plugged in or not, and use that to provide insight. So if we consider a given person over time, we're getting this kind of multifaceted, high-resolution view of things. This is kind of a display of the velocity and the variety. So we might know, okay, based on GPS and based on their report through buttons, that they bathed at a certain beach, Newport Beach in Southern California, where I've done some work looking at adverse health effects of recreational water use, together with a set of colleagues. And we might know when they bathed there. We might have information about when a beach advisory was posted and beach closure notice posted based on electronic information available through websites. And we have information about when they sought care through the EMA interface or through hospital IT systems. And then we may have records on when they encountered highly credible gastrointestinal illness using a button where they report symptoms. And then there may be some measured risk ratings as measured through samples taken from the ocean that reported pterococcus counts or other counts. So in short, when we try to understand a person's health biography or health trajectory, we can have lots of understanding about exposures and outcomes for that individual that give a more complete picture of what was going on at a high resolution level, rather than asking a month from now or 2 months from now, did you feel sick, within the past month? We can actually look on a day-by-day basis about their exposure and their health outcomes in the particulars of the symptoms. Similarly for Lyme disease, I provided you a Lyme disease sample study, and there we might have records where people can report being exposed to a tick. There's a record from GPS about whether they went outside, how long they spent outside. We have records where we can ask them questions. Are you using personal protective techniques like covering up your pants with your socks? Are you wearing long sleeves and shirts, etc.? Are you wearing insect repellent? But we can go through a situation where we can recognize when they removed a tick, when a rash appeared, when they encountered an advisory, sought care, when they encountered joint pain, using the information gathered by an EMA interface coupled with sensor data such as their location in a wilderness area gathered through GPS. So this is an example of sort of the temporal resolution as well as the variety of information. We can also do things like map activity level out over geography. Where are people more active? Where are people less active? This is a graph produced by Mohammed back in the day of sort of social interactions during and after work of individuals. Where are they at different times of the day? Where were their social groupings? Now, this aspect of variety is particularly notable because of an analog to what's called Metcalfes Law. And Metcalfes Law posited that the value of a computer network rises not, if we consider as new people join a computer network, a first user, a second user, a third user, the value of that network to those users rises not linearly with the number of people. It doesn't just go up as you go from 1 to 2 to 3 with corresponding levels, but it actually goes up with the square. And it's because each of those persons being added, when you consider the 10th person, the 11th person, or the 100th person, the 101st, they secure value comparable to all the people that are already there. They can communicate with any of those people. And I think there's a similar argument here for these data streams, these data sources. And it's not just sensor data. I should have expanded that. It's not just sensor data. It's other information gathered via these devices. It may be EMAs, these ecological momentary assessments, these mini questionnaires. The value of this data rises not linearly with those things, but with their square, because you can consider combinations of them. So, if you're trying to understand the timing and social and geographic and spatial context of food consumption, the fact that we can combine Bluetooth to discover social groupings with Wi-Fi to discover where it is inside, potentially with GPS to capture outside as well, together with a record of what they're eating through a picture, that provides us this kind of more complete picture of their social and geographic context of food consumption, which is very powerful. If we want to understand something about, for example, where physical activity, how it changes based on different environments, we can make use of accelerometry data to discover the likely physical activity, but GPS data to understand where they are, the nature of the built environment around them, and Bluetooth based on who's around them. We will also often throw in their accelerometer or gyroscope data and orientation to better capture whether the phone is indeed being even carried by them. Whether they're in a vehicle might be indicated by GPS speed, something Jim is working on back there. So in short, when we're trying to understand in aspects of a person's context, their exposures, their health outcomes, their health behavior, putting together multiple lines of evidence, being able to cross-link them to give a more full view of things is very important. The final component I'll talk about is that final V. Remember, volume, velocity, variety, and now, ladies and gentlemen, veracity. Sort of the truthiness of the data, the level of accuracy of the data. And the idea here is twofold. Individual measurements, particularly physical measurements, can be more accurate often than self-report. Let's consider a child. So Amin there was working on recording stress levels dyadically among children. These are children from 2 to 5 years of age predominantly, but also some infants, together with their caregivers, okay? And trying to understand that interaction. And when you're dealing with very young children, particularly infants, you're not going to be getting self-report, right? You're limited in what you can get. Even when we do have self-report from adults, we know that people are notoriously bad at reporting certain types of things. We know since the NHANES 3 study, the National Health and Nutrition Examination Study in the States in its third wave, that people are quite poor at reporting physical activity compared to what can be picked up with accelerometry. In terms of reporting food consumption, they also tend to be quite poor at reporting intake of fruits and vegetables in certain circumstances. For location, some of our work has found that what people report from memory versus what's actually found if you look at their GPS traces and indoor traces using Wi-Fi, they're night and day different. They're very, very different. In terms of their social context, who are they spending time around? Once again, we found big differences between what they said and what's actually recorded with these devices using tools like Bluetooth. In other words, the device tells one story, they're stating something very different. Their spatial proximity, for example, to each other, along with that social context. Their communicational context is often hard to report. What I read in the past day, what piece of information I was exposed to, what billboards I was exposed to in the States for tobacco-related messaging. These things are often hard to self-report. It's hard to remember reliably if I saw this billboard on the way to work. Also, decision-making rules and heuristics can be hard for people to report accurately, hard to elicit, and exposure to environments and behaviors, to particular physical environments. In health, we often deal with crude proxies, right? We deal with where someone lives, their residential location, as a proxy for understanding their exposures when it comes into the built environment or when it comes to their food environment. But we may actually find, using tools like this, that their activity space is much larger. This is something my colleague Kevin Stanley has looked at. Together with Scott Bell, they spent a lot of time looking at activity spaces, where people actually spend time. So I may live in one apartment, but I actually spend a tremendous amount of time, taking care of my mother across town, where the food environment is very different, where the physical activity environment and supports for physical activity are different. Perhaps I spend a lot of time with my fiance, up at Reserve, or I spend time with other friends in a very different environment. So these elements of health behavior and health exposures are often notoriously difficult to reliably secure through traditional instruments alone. And absent an understanding of these behaviors and exposures, the potential for quantitatively informing policy trade-offs or for understanding the details of the texture of the micro behavior of individuals can be very challenging. In addition, these days, we're dealing with some large challenges. So, for example, random digit dialing, a traditional stalwart of health surveillance systems for provinces and states across the developed world, we're getting declining opt-in. And the people who do opt-in are often highly skewed demographically. Here in Canada, there's a lot of opt-in by older homemakers or older individuals who are retired, and very little by younger individuals who may not have a landline and only carry smartphones and so on. We know that vulnerable groups like intravenous drug users here in the province, being very vulnerable to HIV and Hep C and other components, they're very hard to reach with traditional survey instruments. Door-to-door studies is going to have a hard time picking up homeless populations. Youth, low SES groups, low socioeconomic status groups, so poor individuals, minority individuals, are often hard to reach with traditional tools. And when it comes to things like remembering contact duration, contact patterns over time, the food that is eaten, or the physical activity to which you're exposed, these things are difficult. So the first component of veracity that I tried to emphasize is that individual measurands, these physical measurements where we take a photo of the food, right? We take a photo of the built environment to which we're exposed. We measure using Bluetooth when people are in proximity. Those can be more accurate than self-report. And it's not necessarily due to a moral failing, it's just we have a hard time remembering who we spent time around, who was next to us at the light at Tim Hortons or what have you. Secondly, though, the aspect of veracity in the health context is collectively measuring it. This gets to the variety component. It works together with variety. Collectively, the things that we pick up about a given person for a given interval of time can often offer strong accuracy beyond what's possible with one measurand or with self-reporting. So the ability to triangulate from multiple data sources, from the fact that the phone is plugged in and Wi-Fi is strong, the Bluetooth, the GPS signal is really weak right now and sometimes non-existent. Those, and the fact that the light is on, even though there's strong light, even though it's at night, those point to it being inside. I'm very likely inside from those. Any one of those measurements, very ambiguous. I could be standing in the headlights of a car, the light level is strong because of that. I could be, I could have a weak GPS signal because the phone is in a metal dashboard, etc. But once you start putting them together, you often get a pretty good picture of what's going on. So if we want to classify posture, sitting, standing, lying down, as William Vanderkamp has done a great job with a highly accurate classifier. If we want to know if we're indoor or outdoor, if we're in a vehicle or not, or if we're smoking or not, it's not one measurand that gives us the indication. It's a whole confluence of them. It's a whole package. Again, for smoking, movement of the hand, whether you're indoor or outdoor, aspects of your heart rate variability, your social surrounds, your GPS location, the time of day, time from last use, all of these can be relevant for classifying whether or not you're smoking. And collectively, therefore, we have a much better picture of what's going on health behavior-wise, health exposure-wise, and context-wise using multiple sensors than we would with one sensor or that we would with self-report. So in short, what are some attractive characteristics of health big data? Should be of, not PF. Okay, I don't know what this is doing that. Okay, so what are some attractive characteristics? It's intensively longitudinal. We pick up individual information about an individual over time. We can tell stories about individuals. We get narratives from a particular person that can be very powerful for understanding the dynamics. And increasingly, as we're dealing with life course perspectives for understanding health outcomes, longitudinal data starts to be of considerable interest. There's physical measurements, right, for a lot of things that are hard to self-report reliably. You can cross-link quantitative and qualitative responses. You can, if someone hasn't visited the community-owned grocery store for a while, you can ask them, help us understand why you haven't been there in a while. What barriers have you encountered? Is it transportation? Is the prices too high? Is it just you haven't had a chance because you're too busy? We can ask questions about barriers to physical activity. We noticed that you've been sedentary for a couple hours here based on accelerometry. Could you help us understand, what's getting in the way of that? That ability to tap into intent, the ability to tap into understanding of why we see behaviors is really a powerful feature of this. And it goes beyond what you can get on a smartwatch alone. It really speaks to the powerful combination of wearables and what can be picked up on smartphone for sensor data and EMAs. You can have some sufficient temporal resolution, high velocity, so you can examine, you can help eliminate many effects of recall bias. We can ask someone about an exposure and its outcomes proximate to that exposure. So when they've been in the area of a fast food restaurant, or they're in a park, we can ask them about what brought them to the park now. We can ask them about the effects of whether or not they were exposed to tobacco messaging when they went to buy the newspaper in a newspaper shop. We can recognize many repeated day-to-day patterns and observe many exposures, not just one exposure, but we can observe many. Many exposures to bathing in that beach, in Newport Beach, and how many of them yielded highly credible gastrointestinal illness. We can look at exposures to food, the number of times they ate chicken from a certain restaurant, and look at what fraction of the time they became ill from that. We can look at exposures to particular built environments and ask longitudinally, how is that associated for that individual with a health behavior in the form of sedentary behavior and physical activity? And we can triangulate from multiple measurements to better understand what their real situation is. Are they indoors, outdoors? Or are they in a vehicle or not? Are they proximate to another individual in a way that might lead to norm transmission, et cetera? And finally, and very importantly, there's a lot of, not all, but a lot of automatic collection going on. So you think about GPS, you think about accelerometer, you think about heart rate variability, you think about heart rate, you think about electrodermal response, you think about gyroscope, you think about these features that clue us into where people are, who they're with, what level of activity they're getting, what level of stress they may be experiencing. You start putting those into an automatic context, and it can translate to a lower burden situation than with traditional self-reporting instruments. So that too is an attractive feature of these sort of electronic data systems that we can often tap into. And a lot of what we used to record with PDAs, in health services delivery contexts, reporting who we're with, where we are right now, what behaviors we're engaged in, a lot of those things we can eliminate just by virtue of physical measurements. Okay, so those were some comments on hallmarks of health big data and the 4 V's being an important hallmark. Any questions? I know a lot of information, high velocity, right? Any questions or comments related to this before we go on to one further presentation? Questions, comments? Do you see how this relates to the Ethica site in terms of the velocity here, in terms of the volume? Look here in the thousands, in terms of some of the aspects of veracity, trying to recall, where someone was during a certain period of time, having this recourse to a physical record here, and then in terms of the variety, the fact that we have many measurands that we're recording here. So this is an aspect of sort of includes some aspects of veracity. I can barely remember, where I was at that time, and would probably be true for many people. And then the fact that we're collecting these many measurands to provide this triangulated high resolution, high temporal resolution view. Does that make sense in terms of the 4 V's? I'll take that as a yes. Okay. Okay. Good. We're gonna stop this, and